point of today is that we're going to tell you about the programme that we've planned. We're hoping to talk about the benefits. We'll tell you what we found internationally and how we're going to relate that to the national picture. We're going to let you know about our governance model, and we're going to give you a project overview of where we are and where we're going in the next short while. But first of all, and I don't think I need to do it now after Jerry's speech, I didn't want to take an academic article of what we mean by patient experience. I wanted to take Brian Boyle's book on patient experience, and he said that he was in a near-fatal car accident. He had to be resuscitated 8 times. He was in medical-induced a coma, but he could still hear, he could still see, and he could still feel pain. But I thought the last few lines here were very important, also as he recovered. He said, "I soon discovered that the power of the voice is amplified when the message is of gratitude, that a simple smile cannot be underestimated, and that the body language and tone of voice are critical components within the hospital room." And I think we can say they're critical anyway, but certainly in a hospital room, they're amplified. And I suppose that is why we are all here today, to hear about patient experience and what we're going to do about it. But first, we need to know that patient experience is much more than patient satisfaction. It's focused on individualised care, it's a tailoring of the services to meet the patient's needs, and most importantly, and it's what we heard this morning, it's to engage patients as partners in their care. It is the culture of the organisation. Now, for patient experience, I know there's a lot of patient satisfaction surveys taking place across the country, and they certainly have a huge merit in their own right. But for patient experience, what we are going to do is we're going to send the survey 2 weeks after the patient has been discharged. The reason we're doing that is because of the halo effect. The patient is too vulnerable to ask to participate in the survey in the hospital. So 2 weeks after they're discharged, we're going to send them a survey. 2 weeks later, we're going to send them a reminder letter, and 2 weeks later, we're going to send them another survey pack, which might seem kind of overkill, but it is that third pack internationally that gets the results, and we do want to hear what patients have to say. Another area that we are slightly different in patient experience, it's going to be a national approach. We can benchmark nationally. So we will know exactly the number of people that we are sending surveys to, we will know our target population, and then we will know our response rates. And this is the first time ever, as in Ireland, that we will have such numbers, which will be fantastic for the whole system, because it would allow us to do a benchmark both nationally and internationally. But you may be telling me, I don't have time, we're so busy, we're on the floor. Absolutely. That's what we've been hearing as well. But I'm saying you don't have time not to do it. There's key financial indicators to show the huge benefits of this. If you engage a patient in their care, they get quicker, faster. The discharge rates, the volume of discharge rates fall. The length of time they are in the hospital falls. And the recovery is quicker. And the opposite occurs too. If you are better 1 month after leaving hospital, you will also be improved healthcare 12 months after. So, to tell you further about the advantages, June is going to come up and let you know how it will affect you personally.
Ladies and gentlemen, the holistic way that we are going to measure patient experience across the system is by asking patients specific questions about their whole journey. We will ask them about how accessible the service was, whether they were treated effectively, whether they felt that they could trust the professionals who were providing their care, whether they were involved in the decision-making about their health care, whether they received clear, comprehensive information and support for self-care, because as we know, all of these issues really impact in terms of how people are able to self-manage their health when they're discharged and in terms of how they recover going forward. We will be asking them about physical and environmental needs, their emotional support, were they supported emotionally, and were their families involved? How did, and Family Carers Ireland have a lot to say about this, how are families listened to, how are carers listened to, and how are they engaged? And whether there's continuity and, I suppose, smooth transitions between hospital and community care. Overall, we will get specific ratings in terms of people's overall experience. However, the devil is in the detail. It will be in the specific feedback about particular areas, like involvement in decision making, or whether you were treated with dignity and respect, which will tell us really what is going on across the system. In terms of international best practice, and Tracy has already referred to this, we lag behind in Ireland because we are not systematically measuring patient experience in a scientific and robust way. So this partnership between the HSE, between HIQA and the Department of Health is especially welcome. And Tracy has come up here today, and you would never think it, but she has had her head down all year, sleeves rolled up, and working very, very hard with all of the team in HIQA to get much of this work across the line. From ourselves, from the HSE's perspective, we've been working hard, engaging with the hospital groups. I know Colette Cowan is here today, Morris Power down in Galway, we've met the RCSI hospital group, Dublin Midland Susan O'Reilly. So we've engaged with all of the hospital groups to get their support, buy-in and leadership for this. So this is really high on our agenda right across hospitals. In terms of the patient, it's about moving from a culture which was traditionally very paternalistic to one which is about shifting to treat patients as partners in their own health care. Patients, when treated as partners in their healthcare, as we've said earlier, have better outcomes in healthcare. They're more empowered, they feel listened to, and when we know when things go wrong, when we look at the complaints and when things haven't gone right for patients, what we know is that patients feel that they weren't listened to. And this has come out time and time again, and it's something that we really need to sort of sit up and embrace going forward. In terms of the service provider, this will provide us with very specific information about what are the priorities right across the system, at group level, at hospital level, and corporately. What do we need to be driving in terms of quality improvement, in terms of patient-focused interventions? At local level, it will give us the top issues that we really need to focus on. At group level, how do we enable that and make it happen? Some very good work done in Cork by the CUH Hospital Group 2 or 3 years ago, where they looked at how do we articulate this quality improvement agenda in terms of patient-centred care in a way which spreads out the responsibility for this right across the lines of accountability. So at a one-to-one level, what needs to happen? At ward team department level, what needs to happen? At a group level and at a corporate level, what do we need to do to make sure that this is high on the agenda? It will provide us with the assurance that we need that we're doing this very well and help us to benchmark locally and internationally. For the regulator, it's going to provide information in terms of specific issues which need to be focused on. There will be very rich data which will come through in the qualitative feedback. As Morris Power said in Galway, it's not in actually the questions which people take, but it's in the stories that they write about their experience that we're going to learn so much. And it's when that information is triangulated, that qualitative information, when that's triangulated, when we look at the severity of those issues together with the quantitative feedback, that we will get the full holistic picture. There are two very interesting gentlemen in the London School of Economics, and I know that the Quality Assurance Division are engaging with them, Reader and Gillespie. And they've looked at this across hospitals and they've said, it's not the number of complaints that we need to focus on, it's the severity scores for those complaints and the themes which arise. So it's in looking at this in a very holistic way which will drive accountability. When we look at these surveys, because we will have our skeptics, of course, who will say, what kind of change do these surveys really drive? The surveys drive change when the key themes which are embedded in the surveys are on the agenda for policymakers. So the biggest changes in this area have been where the policy drivers have taken the core issues and at a corporate level have made sure that it's on every single agenda. And we have great leaders in this organisation. Liam Woods last year issued this book, Intelligent Kindness, to all of his group CEOs. And one of the things that's in this, and I want to share it with you, because it, I suppose, really captures the essence of what we're going to find out in this survey. Ability is what you're capable of doing. Motivation determines what you do, but attitude determines how well you do it. And this is what we are going to capture in this survey. Thank you.
We lost it. Where I was going to pick up was the international slides. We did an international review. First of all, yes, so in Ireland, to say that the last national survey was done, and a lot of you will recall it, in 2010. Now, the thing was with that survey, it was done on a voluntary basis, and therefore not everybody participated, and also it wasn't done with a partnership approach. And the strength of the partnership approach is that the Department of Health can use the data to measure what the patient experience elements of their policies and legislation work, and therefore to manage it and to produce policies and legislation that work for the patient. HIQA can use it to make sure that we can identify risk analysis in the system, and it can be a flag for where there are challenges in the system. And HSE plan to use it to do quality improvements on a short, medium and long term at local and national level. So there is huge strength and value added for the partnership. In terms of the international findings, what we found was the partnership model is what is adopted because it has the greatest strength. The governance arrangements need to be robust to make sure that it actually happens. The scope of the survey must be clear because everybody wants a little bit of questions for their area, and that's not possible with one survey. We can't overburden patients in answering a number of questions. The survey tool, they advise that you use internationally recognised questions because then you can benchmark not only nationally but internationally, and also if you purchase the questions you can immediately use the questions. You don't need to cognitively test them, which could take at least a year. Data protection was not an issue internationally. You're allowed to share personal data if you are improving the quality and safety of care. And communication must be robust. So you need to have communication at local and national level, to the public, to stakeholders, to professionals. So it has a strong, robust communication. And commitment, there's a huge commitment required, which all the partners have agreed to, for capital and operations, for financial and HR. And that international review can be found on HIQA's website if you want to read it in more detail. So, in the beginning of January, we got the white smoke to go ahead with this project. So we had to establish a governance structure, develop a survey tool, to develop communication tools, to think about how are we going to engage with stakeholders. There was only a few of us. We need to get out and let everybody know that this is what we're planning. To get a managed service in place so that they could be responsible for distribution of the surveys, and to think about the outputs. Nationally, they produce national reports, group reports, hospital reports, department reports, so we had to think about what we could produce, because whatever we ask, we have to report on. So we established the partnership model with the Department of Health, ourselves in HIQA, we're the lead partners, and the HSE. And we also have patient representatives, and they're here today. Sheila O'Connor and Bridget Doherty from Patient Focus are on the steering group. This was the signing of the Memorandum of Understanding. It formalised the partnership. You can see here Patrick Lynch from the HSE. He's the National Director of Quality Assurance and Verification and the Head of Planning and Performance. We have Phelim Quinn, the Chief Executive Officer of the Health Information and Quality Authority, and Kathleen McLenaghan, one of our hosts here today, the Director of the National Patient Safety Office. Each of the organisations have their own roles and responsibilities. I won't go into the detail there, but the Department of Health provide direction in terms of policy and legislative requirements. HIQA, as the lead partner, need to coordinate and manage the project. And HSE at a national level and at a local level need to drive out the survey and tell the staff and the stakeholders what's happening. Patient Focus are at our steering group meetings, making sure that we represent the patient throughout the programme and let us know that, make sure that we're on track with everything we propose. So our governance structure is robust. We have a steering group with the senior level decision makers from each of the partner organisations, and as I said, the patient representatives are there also. The delivery group is the working group, and that's from the 3 partner organisations, so myself and June are on that delivery group. And the advisory group, again, there are 3 patients on that group to make sure decisions, etc., are done in line with patients' needs and wants. The scope of the survey has been decided, and it's going to be adult acute care, 18 and over, who have stayed a minimum of one night in an acute care hospital. So 1 month will be picked in 2017, and anybody who is discharged in that month will be asked to participate in the survey. In terms of the survey tool development, we purchased an international question set from HIQA Institute Europe, and then we went out and did 8 focus groups. 6 of those were patients, and they were throughout the country. And we did 2 with data users. We then did a Delphi study with 60 participants to bring the library of 189 questions down to a core of 60 and an additional 40. And then we conducted consultation with the international experts, HIQA Institute Europe. And we will have a final survey tool at the beginning of next year. These are the examples of the questions that are asked. There's no data protection issues in the questions, but it is finding about the patient's experience, the patient's pathway, and how they found their care. In terms of communication, we've set up our own branding, and we have also developed, and we have a stand outside if anyone wants to get the frequently asked questions for patients or the patient information leaflet. It gives very detailed information. You can also find out more information on our website, patientexperience.ie. We are also in the process of developing a survey pack. What we measure, we must report on, and we're very, very clear on that one. So we do plan to produce a national report. We plan to produce hospital group reports for each of the 6 hospital groups that will be participating, and we plan to produce 41 hospital reports for each of the 41 hospitals that will be participating. And as June said, there's going to be clear quality improvement plans in place for each of the hospitals and the hospital groups. And the quality improvements that have resulted because of the patient experience will be up on the website. And the purpose of all of this is, of course, that we all have the right information, that we understand exactly what the patient perception is, to give better patient care and more effective and efficient organisations. We're also looking at a managed service, and the point of the managed service is that they will develop a more interactive, user-friendly website to allow online responses, and also to allow for the service users and for the patients to be able to access their own areas of interest. So the key points at the end of 2016, we've achieved a partnership approach, we have a robust governance structure in place, we have a survey tool almost ready for finalisation, we've got communication tools in place, and now we're starting our stakeholder engagement plan. And we are looking at a managed service who will distribute our surveys. So just to remind you one last time why we're doing this, the length of stay in MCG's Neuroscience Centre after doing a project like this unit decreased by 50%. Their discharges volume increased by 15.5%. The staff vacancy rate fell from 7.5 to 0%. And the most important thing was the change in culture, and that's why the staff wanted to stay and the patients were taken better care of. So in conclusion, Leonard Kish tells us that if patient engagement were a drug, it would be the blockbuster drug of the century, and malpractice not to use it. However, I do think the last bit, what Karen Luxford says, that consider patients central to your care team, and then we'll be on the right care pathway for future. Thank you very much. That's our...
Okay, it's great to see organisations working together and collaboratively looking at and listening to what the patients have to say and the feedback. At the end of the day, the patient's perspective on their care is unique. They are legitimately positioned to evaluate the care and services. And I suppose from my perspective, I would say, you know, just all healthcare workers, every one of us working in healthcare may even think about that prior to 2017, because patients and carers know exactly what's going on and what's going on about them, and their what would you say, their perspective and outcomes can vary dramatically from what the healthcare professionals' perspective is. So listening to the patients is hugely, hugely important. So thanks, Amelia, for that. Do you want, we'll open up to the floor. I think we've got some time. Loretta, have we? I think we're a few minutes if anybody has any questions. To the ladies, I'll hand it back to you. She'll be back in a minute. It's coming, it's coming. It's coming. It's okay, Laura, it's all right. We got lots of time. We are, 15. That's why you're doing questions.
Yeah, thanks.
Is this on? Yeah, okay. I'm Jamie Saris, medical anthropology, Maynooth University. Hi, Jim.
Hi, Jamie.
I welcome the survey, but you spent a lot of time on the survey, and I mean, there's a consistent trend in surveys for patient care in Ireland is almost no matter when you ask it, they rank the service extremely highly. I mean, Irish patients seem to be very friendly to the services. And I just wonder how you're going to use that methodology to really frame and actually deal with the stories that presumably you're trying to get. It wasn't kind of clear in the presentation. And if so, what other things are you going to add to the survey to actually figure out, well, how would we take that theme into, you know, the change of practice, which is not something that's going to be done by an algorithm or somebody who sells you surveys, even if they tell you that they will do that.
That's a very good point, and you're right. And internationally, the King's Fund have just published a report saying that sometimes these surveys tell us the same thing. But when we look at the key issues within the surveys, like patients being involved in the decision-making about their health care, usually that rate's much poorer, despite the fact that patients might give an overall score of having had a very positive experience. So it's the specific issues within the survey and the questions that are going to be included therein which will give us the detail that we need. And the qualitative, heretofore we've been lacking in terms of having a taxonomy or a framework for conducting the qualitative analysis. And these two gentlemen I referred to, and we're considering how we will apply this type of methodology to this qualitative analysis that we will receive, have looked at this internationally. They've done phenomenal work, and they've itemised all of the kind of issues which people give feedback about in terms of their hospital experience. So this is very useful to us because it's going to help us with scoring or mapping the feedback against a severity rating and also theming that data, that feedback. And that's where we will get the richness. It's that information combined with the very specific questions in the survey that will tell us where we need to move to. And I suspect, you see, people's expectations have changed. 10 years ago, if you had asked people about overall ratings of experience, mostly they would have been, you know, as you say, very happy. But there's a generational shift. There's this generation, if we call it the Generation X, you know who I'm talking about it. It's the 40-somethings who they're going to challenge. They're going to take pictures of their parents' experience in hospitals. They're going to pull out their laptops, Google the issues, the procedures, the protocols, and the prognosis, and they are going to ask questions. So their expectations have changed, they've moved, and the scorings may not be as high as we anticipate, so it's going to give us very constructive feedback.
Thanks, Joe. Any more questions? There's a hand on there.
Can I just add to that and just say that's why we're doing the survey after the patient leaves the hospital as well, because we do believe we will get more honest answers, and we have clearly laid out in the patient information leaflet outside that they're anonymised responses and they won't be going back to the hospitals. So that will help to get the honest responses as well that we're looking for.
Ladies.
Tracy, thank you very much for your presentation. Kathy and I work in disability services. I suppose, and I have worked in acute services, I see a missed opportunity here in terms of the full pathway of the patient. We have missed primary care and we have missed the aftercare of acute services. So acute services, to some extent, is only one step in the process. So I was wondering, was there any particular reason for that?
Okay, I would just say that this is just the first step, and this is the first survey, and we had to decide, and it was decided to go for the acute care. After that, we will review, and we may extend the programme. Okay.
Thank you. There's a lady there and another lady there. I think we'll have time for two more, yeah.
Hello, my name is Ruth Hunter-Nolan. I work in the haemophilia service in St James's Hospital, and similarly I was going to inquire about the extension of the scope of the project. Obviously our patients would be regular users of the outpatient service, and I would hope that it would be extended to our regular use of the outpatient service. But I also had another couple of queries in relation to who would be collating the results, and also would staff in the microsystem, the frontline staff, would they be receiving the results for their own areas? How would they be supported in initiating any changes? And also, I suppose, if changes had been successfully implemented, how do we share that learning amongst, like in your own individual hospital and to the other hospitals? So,
okay, you raised very good points there. The first point in terms of extending it, which is something there's a lot of policymakers here and decision makers, so that's a really good point to be highlighting in their presence, and that's something that needs to be considered moving forward. Just to say, starting off in hospitals is a mammoth task, because to get representative feedback right across the system, you need to have those sample size high enough so that you can stand over and produce robust data. So it's a mammoth task to go out and survey 30,000 patients in the first instance. So that we need to look at how we do that more systematically going forward. So that's the first point. In relation to the quality improvement projects for your hospital, and specifically more ward level, team level data. This information will give you a nice ballpark information for your hospital. Now, I know that this may not give you specifics for your ward or team, but what it will do is we'll prioritise some cultural issues right across your hospital, which will filter right down to from board to ward. So you would have recalled, I mentioned earlier, nice specific work that's been done down in the south around articulating the issues which need to happen from board to ward. So the benefit is going to go right across your hospital, I would suggest. And we're very happy to engage with people, to hear your thoughts, and you will have better solutions and ideas about what's going to work in your area, and we would be really welcome to hear from that. And indeed, to say as well, in some of the areas, just about this information that's going to come back, we're going to have representative data which will prioritise what the issues are and what important issues are for patients at local level. And I have Olive Gallagher is here from Galway here today, and Olive facilitates a patient forum in the Galway area. And this data, this information will prioritise the patient-focused interventions that they will want to drive in the West. So it's going to give you that rich kind of information.
Can I just say we're going to take one more question before the next presentation, but I'm sure June and Tracy are around for lunch, and I'm sure...
Yeah, if you come to the stand outside, we have it fully manned. Do come out if you have any questions.
Yes.
Yeah.
Okay.
Eilish McAuliffe, Professor of Health Systems, UCD. I was also going to make the point that was made already about extending it beyond the hospital sector. But a couple of other questions I had, and the first you may not be able to answer, but why was this survey done internally rather than contracted out, such as the employee engagement survey, for example, was contracted out of the system?
Well, it is completely independent from the point of view that we have the partnership on board, and the analysis, the data analysis, will be conducted by HIQA. So the HSE are not conducting the data analysis. That's being done external to the organisation. And this model is, we're replicating the models which are done abroad, internationally in the UK, in New Zealand and so forth. So it is independent from that perspective.
Okay, my second question really is about, I mean, it's a huge effort. It's a huge amount of work. I can see that in terms of setting up any national survey like this. And sometimes, the problem becomes that the aim is to get the survey and to get the results of the survey, but the aim is to improve the service.
That's right.
So I'm just wondering what has been done in that regard in terms of putting a system in place to take the results back into the system, and not in terms of individual areas, but is there an overarching framework and plan to improve the service? And what has been done elsewhere in that regard in terms of the picker survey or instrument you're using? Have they used it in other countries to improve the system substantially?
That's a very good question, and I've been in the firing line myself. I stood up at a presentation like this not so many years ago, And I was challenged, well, June, these are lovely results. Now, what have you done about it? So this is where the success or failure of this project lies, whether or not we've responded to the issues. And we're acutely aware of that. I've met the group CEOs right across the country to get their buy-in and support to drive quality improvement initiatives on this agenda. And I'm delighted Colette Cowan is there sitting in front of you. Colette recommended that we should have short, medium, long-term objectives in terms of responding to the quality improvement issues. And indeed, a lot of the work that's going on across the system recognises the importance of this. And so this will be how we will address this. We have management, leadership and buy-in and support to respond to the key issues. A lot of them will be about strengthening and improving what we're doing in terms of culture improvement initiatives. And in fact, when we look at the key issues which will arise in this, some of them will be around, I mean, the main driver for this, for positive experience, we know, is whether patients are treated with dignity and respect. And in fact, if staff are treated with dignity and respect, impacts on that. So Rosari Mannion from HR is doing a huge amount of work and providing huge leadership on that agenda. So it's all of those forces coming together and working on this will make an impact in the long term.
Thanks very much, June. Thanks, Tracy, and thanks everybody.